Great. Thank you so much for all the people who have actually staying back for my last talk. So you already heard ventilation strategies, and now I'm going to be focusing on the non-ventilation part of BPD. Again, I think as you heard from Daniel also and from Eduardo, the focus is to try to get the tube out. That is really the most important thing that we can do to try to decrease inflammation in the lung and prevent the baby from getting into severe BPD. But there are other things, and you've heard Daniel talk about vitamin A and caffeine. And again, this will be a very practical talk. I'll give you doses when we start, when we stop, how we do it, as we go along, how I manage the fluids and things like that. For some of you who may not have joined me earlier on for my earlier talk, just to remind, when I talk about BPD, I still am using the clinical definition for most of my outcome measurements, which is assessment at 36 weeks postmenstrual age. And you have to have 28 days plus of requiring supplemental oxygen more than room air. And depending upon whether you're needing room air or you're needing positive pressure support, you will have mild, moderate, or severe BPD. This again is a repeat slide from my previous talk, but remind everybody once again that BPD is a multifactorial disease. It's genetic factors along with some environmental factors interacting with it, ventilator trauma, specifically invasive ventilator trauma, infection, pre or postnatal hyperoxia exposure on a bedrock of immature lung with or without RDS, leading to inflammation and cell death, which leads to lung injury. And here, in more details about what the new BPD looks like. So you have these factors mentioned above here, prenatal factors, hypertension in the mom, hypoxia, infection, smoking, genetic susceptibility, and the lack of steroids, mechanical ventilation leading to volutrauma, barotrauma, and electrotrauma because releasing of these inflammatory markers and agents, hyperoxia causing damage by DNA, lipid peroxidation, and protein oxidation, again releasing cytokines that can be damaging to the lung, which leads to aberrant tissue repair, and dysregulated vascular and alveolar development with the new BPD. So essentially, you can think of BPD as components of 4 different components. There is maternal factors, antenatal factors, infant predisposition, oxygen injury, and mechanical ventilation. So the effort is to try, and you can't do much about the genetic susceptibility, not yet anyway, but obviously there are the therapies, experimental therapies working on manipulating that. One can at least try to do something about the maternal factors. At least from our side, we can try to push for giving of antenatal steroids and try and prevent or decrease the mom from smoking. For mechanical ventilation, you've already heard my previous talk as well as Daniel's talk. So the effort is to try and get the baby to non-invasive support. And for oxygen injuries, to try to minimize the exposure to the high concentrations of oxygen. I think this is very important, and you always need to be very good friends with the maternal fetal medicine or your obstetric colleagues. And so whenever you come in the unit in the morning, I would highly recommend you go and say hello to them and just remind them, please give antenatal steroids to the babies who are threatening to deliver early. While this has not been shown to decrease BPD in multiple studies, however, it does decrease the severity of lung injury and lung disease in the early stages. And this might help you to get the baby onto non-invasive support, which eventually might make an impact on decreasing BPD, or at least the severity of BPD. So highly recommend. In the US, we are pretty much approaching almost 95 to 98% in the centers that really make a strong effort to try and use this. Oxygen use. This is the next drug, and it is a drug. So obviously, like any other drug, there are specific indications and specific side effects that you have to be aware of. And we start off from the delivery room. Our default strategy is using somewhere between 30 to 40% oxygen. Most of the time, we put the FiO2 setting at 0.3 for a preterm baby. We use CPAP in the DR, and sometimes we will also use NIPPV using the T-PACE resuscitator. If we need to use blow-by oxygen, then we increase our FiO2 to 100%. But again, the effort is to try to give the oxygen through the blender and to try to not use beyond 30 to 40% initially if we can avoid. And again, keep in mind that the oxygen saturation is at birth for the first 5 minutes, and there are Dawson curves from Australia that you can look at at what oxygen saturation. So we try to aim for reaching an oxygen saturation of about 85% in about 5 minutes of life. So there is enough time, and we don't want to rush to increase the FiO2 very quickly soon after birth, because after all, the baby is deficient in antioxidants, and we do not want to expose the reactive oxygen species to this immature lung, which will obviously cause more damage and injury. So during the first few minutes of life, a saturation of 70 to 80% may be acceptable as long as the heart rate is increasing, baby is ventilating, and SpO2 is increasing. If the SpO2 is less than 85% at 5 minutes, then only we start increasing the FiO2 from 40% and beyond, and we deliver it through the blender. We usually increase it by about 10%. If the saturation is more than 93%, we will actually decrease the FiO2 right in the DR itself, just trying to maintain the saturation parameter somewhere in the 89 to 94% in the recommended range. And so our recommended target is 89 to 94%. We start doing that right from the DR, and we will then, when we move to the NICU, we will keep the alarm limits in our monitors at 88 to 95% for less than 34 weeks babies on supplemental oxygen. For babies who are more than 34 weeks, just supplemental oxygen or with ROP stages 2 to 3, where we are obviously concerned about pulmonary hypertension, we will increase our target to 93 to 97% with alarm limits of 92 to 98%. Drugs. So oxygen, once again, I want to remind everybody it's a drug, and so its main use is prevention of hypoxia or hypoxemia and as a pulmonary vasodilator. As I mentioned in my earlier talk, in the early and evolving phases, we will titrate the FiO2 to keep it around 89 to 94%, and generally more than 88 and less than 96%. In the established phases, we use 93 to 97% for prevention management of pulmonary hypertension. Methylxanthines, you heard a lot about it from Danielle and also initially also from Eduardo. So keep in mind that caffeine is a very nice drug. It has a very large therapeutic to toxic ratio. In other words, you can use higher doses without getting too worried about the side effects of it. And so we routinely do not measure levels, as you already heard from Danielle, and we tend to use it early, and we tend to use it for a longer period of time. It's not only a direct respiratory stimulant, it decreases diaphragmatic contractility, it's a weak bronchodilator and a diuretic. So it has multiple actions, and so that's why we think it definitely seems to be associated and been proven to be shown to decrease BPD. And as a follow-up of the CAP trial, it also improves neurodevelopmental outcomes. So our dosing range is caffeine citrate 20 per kilo, loading dose, and 5 milligram per kilo maintenance dose. And we can go up to as high as 10, sometimes even up to 12 milligram per kilogram per day maintenance dose. There are side effects with feeding intolerance and tachycardia. That is by definition more than 180 per minute, which is consistent, but it is rarely seen, and we are able to maintain the baby on caffeine, and we find that it is helpful in keeping the baby out, keeping the baby away from the endotracheal tube. Vitamin A, you heard about the potential benefits of it. It helps in maintaining epithelial cell integrity of the respiratory tract. I think part of the reason why it has not really been that beneficial is that vitamin A levels in preterm babies is reflective of the maternal vitamin A status. And the original study by John Tyson, had a lot of population from the southern part of USA where there is maternal undernutrition or lack or levels or lower levels of vitamin A. And so the babies may have been deficient in vitamin A. And I think you saw a slide from Daniel where he talked about that it seems to be more beneficial where the baby has lower levels of vitamin A. So if you have normal or near normal levels of vitamin A, it does not really improve the respiratory epithelium. However, if there are deficient levels, then it does seem to help. And the dosing that is recommended based on the randomized trial is 5,000 international units. I am given 3 times per week for 4 weeks. It's starting at birth, but you heard a different regimen that Daniel uses. So you can think about using one or the other as per whatever the level of comfort is in your unit. Diuretics. Now, diuretics is essentially to decrease pulmonary edema. It's only transient improvement in lung function. It doesn't seem to prevent or decrease BPD, but at least in the first few weeks of life, we do find that we're able to decrease our requirement of the fluids, and also might be able to decrease the ventilator settings and FiO2 requirement to some extent. It might also be helpful in managing PDA-induced pulmonary edema. The drugs that we tend to use in the first couple of weeks of life tends to be furosemide, and the dose is 1 to 2 per kilo per day or every other day. In the chronic phase, mostly in the evolving in the established phases after 3 or 4 weeks of life, we tend to use chlorothiazide 20 to 40 per day, sometimes alone or sometimes with spironolactone, depending upon whether we want to add sodium chloride and potassium chloride to the supplements. It is very important to keep an eye on the electrolyte abnormalities. Keep in mind, long-term use of furosemide also leads to nephrocalcinosis and osteopenia of prematurity, as it is a calciuric drug. We tend to keep the sodium levels around 132 or more, because if you have sodium levels higher than that, you will tend to retain more water, which again makes you need to give more diuretics. But if you have lower levels of sodium, serum sodium of less than 132, your growth of the baby is going to get affected, because sodium is a very critical part of the sodium potassium ATPase pump and very important for every cell in the body to be healthy. So it's a little bit of a fine balance of giving enough diuretics to keep the baby on the dry side, but also not giving too much of diuretics to make the baby having severe electrolyte abnormalities and the problems thereof. Bronchodilators. Now, bronchodilators obviously is meant to open the airways, but preterm babies may not respond to this very well, depending upon the amount of smooth muscle that they have. I pretty much restrict its use to evolving and established phases. The ones that I'm more comfortable using is the albuterol or salbutamol, and the dose is given over there. And there has been studies done that actually if you give it to an MDI with spacer, you will actually deliver more and have a better response. We actually did a randomized control trial showing that to be the case. And it is again effective treatment for reversible bronchospasm, although long-term use has yet to be established. I tend to use it in babies who are bigger, where I will try it and see if it makes a difference in terms of air entry before and after using it. And if it does help, then I will use the dose given Q8 3 times a day. The other one for muscarinic antagonist is Apotropium Bromide, and that again, using it with a nebulizer MDI, the dose is given on the screen, can be used as adjuncts in patients who are significantly responsive to albuterol, who are not responsive. So if you have a baby that is not responding well to albuterol, you could try that. It may be better tolerated than albuterol because in babies with tracheal bronchomalacia, apotropium, it does not create that kind of a potential bronchospasm in that situation. So that might be helpful in terms of also decreasing your secretions. These are some of the drugs that can be used. It is listed over here: albuterol, terbutaline, and the different trade names, preparations, and the doses that can be used for the anticholinergic agents, which may be used as an adjunct or in place of other. You can see the doses listed over there. These slides have been sent to Rajiv, and he can share them with you as time permits. Keep in mind that these drugs are helpful only in the short term, has not really been shown to make a difference, but in a particular baby, using this in adjunct with the other supportive therapy you may be giving might help you to decrease the ventilatory support that you are providing, and may in some situations even prevent the baby from getting intubated if you are already non-invasively supporting the baby. Postnatal steroid. Now, this is something that has been talked about, and again, it is meant to decrease inflammation and pulmonary edema. I tend to use dexamethasone and in the evolving phase, and this is mostly when I'm trying to extubate the baby. So you have, and I try my best to keep the baby extubated between 24 to 72 hours of life. And if they do get reintubated after that, then I will use diuretic for the first couple of weeks. And after about 3 to 4 postnatal weeks, if I still have a problem in getting the baby extubated, I would use the dexamethasone. The dosing is based on the DART trial. Usually within 48 hours, I'm able to get the vent settings down enough to get the baby extubated. And then I too obviously try my very best to keep the baby extubated. In the established phase, that means after 36 weeks of postmenstrual age, if you still have a baby who's on non-invasive support or even on, say, nasal cannula, something like that, and is on oxygen, prednisolone might be helpful. The regimen is given on your screen. Is 2 milligram per kilogram for 5 days, then 1 milligram per kilogram for 3 days, and then 1 milligram per kilogram every other day for 3 doses. And this has been shown it's a study published in Pediatrics. where it has been shown to be helpful in weaning oxygen and getting the baby off oxygen and potentially getting the baby home. The side effects of steroids, as you are well aware, include hyperglycemia and hypertension in the short term. In terms of other drugs, steroids that have been used, I want to mention a couple of studies, and this is the hydrocortisone study. It is a double-blind, placebo-controlled, multi-center randomized controlled trial, 1-to-1, less than 28 weeks, gestational age babies, and IV hydrocortisone was used at 1 milligram per kilogram per day for 7 days, followed by half of that for 3 days, and the outcome was survival without BPD at 36 weeks. The reference is given at the bottom of the screen. And here you can see the results of that study. Survival without BPD was just significant at 60% versus the placebo. There was no difference in the other outcomes, but if you look at the sub-hoc analysis over here, you will notice that if you happen to be a female and if you did not have infection, you obviously had a better outcome. And this is obviously something that you have to keep in mind if you are thinking of using low-dose hydrocortisone. For babies who were given low-dose hydrocortisone, you also had a higher rate of getting extubated, as is shown by the data on top with a p-value of 0.0002, 60% versus 40%. There was no difference in the other adverse events in the babies who got hydrocortisone. Supplemental oxygen was also, weaning off from supplemental oxygen was higher in the hydrocortisone group, and the babies had less amount of PDA ligation in that same group. When they did a little bit of more of a detailed analysis, what they found, essentially, once again, that I want to mention, when they controlled for some of the factors, is again becoming the female, being a female, having less infection and it was more protective. However, there is a risk of increased sepsis in the babies who were given hydrocortisone. So the neurodevelopmental outcome was a follow-up study which was published on 2019. For surviving infants 24 to 25 weeks, they found significant improvement in global neurological assessment in the hydrocortisone compared to the placebo. The risk of moderate to severe NDI of 2% and 8% respectively, no difference in the bigger babies. So the smallest gestational age baby, there was some improvement, and similar risk of moderate to severe NDI of 9% in both the groups. So what about individual patient data analysis, where they compared 5 eligible studies? 4 of them were randomized controlled trials, had individual patient data available. So we are talking about 982 babies that were evaluated. And they looked at early low-dose hydrocortisone for 10 to 14 days and significant increase in survival without BPD. However, there are 2 caveats that you have to remember. One is that they did see a significant increase in spontaneous intestinal perforation, especially if you were giving indomethacin, whether as prophylaxis or something for treatment of PDA, for example, prophylaxis for prevention of IVH or treatment of PDA in the first week of life. Also, the babies who got low-dose hydrocortisone had increase in the late onset sepsis, which was significant. But in the combined analysis, there was no adverse effects on death or 2-year neurodevelopmental outcomes. Okay, moving on to inhaled steroids. And I will summarize this information at the end, at least to give you the way we handle it, at least in our unit. So if you look at inhaled steroid, it was used budesonide, 2 puffs given for 14 days initially, and then 1 puff every 12 hours till last dose of study drug. And the study drugs were given till the infant no longer required supplemental oxygen or PPV, or reached 32 weeks post-menstrual age regardless of respiratory support. And the outcome was the composite outcome of death and BPD at 36 weeks post-menstrual age. If you look at the composite primary outcome, the p-value just hits 0.05. So the odd ratio does not touch 1, so you could say it is significant, 40% versus 46.3%. So while it is significant statistically, I'm not sure I would call it clinically significant that it was protective in that sense. Survival without BPD, with BPD was lower, 27.8 and 38% if you remove the death. But remember that this is not the primary outcome, so this is the separate outcome that they're looking at. This is a little bit of a busy slide, but it basically says that also you'll note that the incidence of PDA was lower in the budesonide group, as well as treatment of surgical ligation. So there was that additional benefit too. Reintubation rates were significantly lower in the budesonide group versus the placebo group. And the supplemental oxygen requirement was 0.05. So the other study was the study done in the USA and Taiwan. What they did is the inclusion criteria was within 4 hours of birth, less than 1,500 grams, severe RDS, FiO2 at least 50%, and the control group only got surfactant. In this study, it was Survanta, while in the study group, they got surfactant plus budesonide, as mentioned there, and it was given as every 8 hours till they were maximum of 6 doses. Primary outcome, once again, was death or BPD. And in this study, they found that BPD or death was significantly lower. This is intratracheal budesonide. Just to clarify, the previous study that I mentioned was through inhaled, but this is intratracheal. And you can see that death or BPD was lower in the babies who got intratracheal budesonide. Severe BPD was also lower. When you look at their follow-up data, they did not find any significant difference, which means you could argue that it was not harmful. A meta-analysis of 2 clinical trials where intratracheal budesonide has been given with surfactant, they found that budesonide surfactant mixture demonstrated 43% reduction in the risk of BPD with a number needed to treat of 5. Mortality was not different, and a 40% reduction was observed in the composite outcome of death or BPD in the budesonide, intratracheal budesonide surfactant group with a number needed to treat of 3. So this is very interesting and hopeful, but I think we still need more data to try to see if this is something that should be clinically recommended. One of the other things that I want to highlight is something that has been worked on, which is using CPAP or NIPPV with MIST or LISA, MIST being minimally invasive surfactant therapy or less invasive surfactant therapy using the catheter. So this is a study from Turkey where they compared babies on CPAP versus NIP using MIST or LISA, 100 babies in each group. And their primary outcome in this situation was looking at need for invasive ventilation the first 72 hours of life or requiring surfactant. And you can see the babies who were on an IPPV, 13% versus 29%, and for the surfactant, 38% versus 60%. Also, you will see over here that the risk of BPD was lower, was 7% in the NIPPV group versus CPAP of 16%. So this is something that seems to be very, something that's very hopeful. And we are awaiting studies, some recent study that has just been completed. There was also a comparison in the same study from the Turkish study. They actually had a table where they showed between data from other studies that have looked at CPAP versus NIPPV, but they were the only study that have actually combined minimally invasive surfactant therapy, and they showed that it was beneficial when you combine NIPPV with minimally invasive surfactant therapy. Okay, so let me try and summarize what the data that the studies that have been done so far. So I think in terms of the low dose hydrocortisone need to balance benefit versus risk, we don't tend to use low dose hydrocortisone right now because we are focused, like I said, is to keep the baby extubated right from the start. And we will try our very best to keep the baby extubated using the NIPPV strategy. We will use postnatal steroid dexamethasone after 3 to 4 weeks of postnatal life, but that is not very often. So I think in your unit, you'll have to decide whether you're okay with the other, with the risk of late onset sepsis and risk of perforation if you're interested in using low dose hydrocortisone. Inhaled budesonide, while it was initially, the p-values are clinically not, p-values may be statistically significant, but I think there is some concerns, even though it was non-significant, there was a concern about increased mortality in the inhaled budesonide group, and long-term, 2-year confirmed statistically significant increased mortality. Hence, I would not recommend that we use inhaled budesonide with the current data that is available. Now, the steroid and surfactant approach of intratracheal approach, especially say if you can combine it with the Ensure, seems promising, but it requires confirmation with a larger sample size study along with the developmental follow-up. The one that I'm most excited about is the use of NIPPV with surfactant using MIST or LISA approach. Additional randomized controlled trials are needed for this outcome of BPD, And I am aware that the Peter Dargaville study has just been completed, and I do hope in the PAS study, in the PAS Periodic Academic Societies meeting, this will be presented, the data, and will help us decide whether this approach, where you can minimally invasively give surfactant and then switch and keep the baby in NIPPV, it will try and decrease the outcome of BPD and or death. So to summarize, the non-ventilatory approaches or the pharmacological management of BPD, oxygen, again, more than 89%, less than 95% should be a target. Caffeine, please use it. Diuretics, yes, we do use it, but be careful. And if you use long-term, the side effects can be troublesome. Bronchodilators may be helpful in established and most evolving and established BPD. Steroids, be selective in using steroids. And at the moment, I think I would probably only just recommend DART. And I've shown you the data why I would not recommend any of the other ones based on the data that's available. Vitamin A might be helpful, doesn't seem to be any harm. But again, you have to treat about 14 to 17 babies to really get the benefit in prevention of one BPD. What about some other factors besides these drugs that is very important? And sometimes people forget. They're so focused on using these medications that sometimes very other important stuff that we can do to try and at least decrease the risk of BPD. Number one, fluids and electrolytes. Try to keep the baby dry. This has been shown over and over again by different people, analysis, randomized trials, as well as by retrospective analysis. Keep the baby on the dry side. We tend to keep our smallest baby around 80, and then we go up to 140, but avoid sodium in the first few days of life if you can in the TPN or however you're giving the fluids, because that will avoid too much of water to be retained in the body, because you really want the babies to start losing some weight and get rid of the extra water in their body. Nutritional support is extremely important. We actually start with the protein in the TPN right from the birth. So as soon as the baby is born, gets an IV, we will use what we call starter TPN. It has glucose and protein, does not have lipid. We start lipid the next day. We'll start with 3, go up to 3.5, and then 4 grams per kilo per day. With fats, we'll go up to 3. We will start with breast milk, colostrum within 24 hours. And there is some data, not randomized control trials, but there is some data suggesting that breast milk might decrease the risk of BPD, so highly, highly recommended. We have recently established donor breast milk in our unit, and so we use it pretty much for every small baby if the mom's own breast milk are not available. So while we try to keep the fluids on the lower end, we also try to make an effort to increase our caloric intake, and we try to reach around 120 to 140 kilocalories per kilo per day, again, keeping the fluids on the drier side. PDA, we investigate only when we feel that it is clinically significant. We tend to use indomethacin or acetaminophen or Tylenol if we have to close it, if you're not able to extubate the baby. I don't know whether I would say we use 3 courses. Sometimes we only use 1 or 2 courses because now that we have transcatheter closure, the complications of surgical ligation are not really seen with this, and we have some experience, at least in some babies that we have sent for transcatheter closure. So that might be something to think about if the PDA is a problem in your unit. So to summarize, I think oxygen supplementation, keep your saturation between 89 to 94%, and really the nursing effort to keep the nurses involved and very much invested in keeping the saturations, and because till we get the automated loop, FIO2 loop systems in place in all ventilators, I think we have to depend on the nurses to try and keep the oxygen saturation within the range so that we avoid the damage because of high concentration of oxygen. Caffeine obviously helps in keeping the baby extubated. It's been shown to decrease BPD, and we tend to use it as long as the baby is getting respiratory support. Until at least it's more than or equal to 2 liters of nasal cannula, we will use caffeine. Vitamin A, in select cases, we do not routinely use vitamin A in our unit, but obviously in some centers it has been found to be helpful and might be adjunctive therapy. Keep the babies on the restrictive side and definitely focus on providing good nutrition, and especially if you can get breast milk, that would be really great. For the evolving phase, the same as early phase for the oxygen, xanthines, and vitamin A. Steroids, again, we tend to use the DART, and only if we need to try to extubate the baby. Diuretics, usually we start around second or third week of life, but we keep a close eye on the electrolytes and make sure that the baby doesn't get into hyponatremia or hypokalemia. Again, focus a lot on the nutrition. For the established phase, we increase our oxygen saturation targets a little bit higher because we want to try and make sure that the pulmonary vasculature is nicely vasodilated and try to prevent or at least decrease the severity of pulmonary hypertension if it's going to happen. Oral prednisone may be useful in weaning oxygen, especially if you're trying to get the baby home and the baby is only on some type of nasal cannula support. Diuretics and beta agonists and anticholinergics can be used. Nutrition is, again, one of the major ways we are able to make the lung grow. The good thing is the lungs do grow. They grow maximally in the first 2 years of life, but babies do make alveoli even up to 8 to 10 years of life. So if you can provide good nutrition, you might be able to get the lungs to overcome the damage they may have suffered in the first few weeks of life. We obviously highly recommend using RSV and influenza prophylaxis vaccination to avoid the hospital readmission due to lung injury. With that, I'll be happy to take questions during the discussion session. And here are a couple more books and chapters. You can go through them and you will find some very useful information in them. Thank you so much.